Hi, my name is Kimberly Elvington, and I am a family nurse practitioner student at Francis Marion University. And today we're going to talk about hearing loss. The objectives for this presentation will be to discuss the different types of hearing loss, causes and risk factors associated with hearing loss, diagnostics and testing, and treatment of hearing loss, and also the geriatric considerations of hearing loss. So there are really two types of hearing loss: sensory neural hearing loss and conductive hearing loss. Sensory neural hearing loss is a type of hearing loss when there's damage to the cochlea or the auditory canal. So that means it affects intensity or loudness and the clarity. Conductive hearing loss is when the sound waves are blocked from reaching the inner ear. And it doesn't affect the clarity, but it does affect the loudness. Now, at the top here, we talk about presbycusis. Presbycusis, you see, is age-related hearing loss. And that is actually a type of sensory neural hearing loss. So causes or risk factors associated with hearing losses, it depends on what kind of hearing loss it is. With sensory neural hearing loss, aging is one of the risk factors or causes, because presbycusis is age-related hearing loss. Noise exposure, ototoxic drugs, infections, trauma, and head injuries. Now, conductive hearing loss could be cerebrum impaction, recurrent ear infections, otitis media, otosclerosis, trauma, and even a tympanic membrane perforation. So, is there a way to tell the difference? How do we know the difference? Well, to start with, we'll start with presbycusis, which is a type of sensory neural hearing loss, and that's generally gradual and bilateral. For that, when you start having an age-related hearing loss, people appear to be mumbling. Now, sensory neural hearing loss in general will have ringing in the ears or tinnitus, decreased clarity. These patients will have difficulty following conversations. With conductive hearing loss, there will be muffled or decreased hearing in either one or both ears. The ear could be painful, it could feel full, actually have discharge. This hearing loss is actually going to improve if you turn the volume up or get them a hearing aid. So, different tests for hearing loss. Well, the first test we'll talk about is the Weber test, and that is when a tuning fork is placed on the top in the middle of the patient's head. And a patient that has normal hearing will hear that sound in both ears. Okay, but a patient that has sensory neural hearing loss, that sound is going to lateralize to the unaffected ear. If they have conductive hearing loss, that sound is going to lateralize to the affected ear. The Rhine test is also using a tuning fork, and you put that actually on the mastoid bone behind the ear and then in front of the ear. And with that, with normal hearing, you're going to have air conduction will be better than bone conduction. Now, if they have some kind of abnormal hearing, bone conduction will be better than the air conduction. So otoscopes, we can look at people's ears. What do we look for? Well, if it's a normal ear exam, it's probably sensory neural hearing loss. But with conductive hearing loss, what could you see? You could see impacted cerebrum. You could see signs of infection like an otitis media. You could see a perforated tympanic membrane. Audiograms. Audiometry is actually the gold standard for evaluating hearing. So with sensory neural, there are decreased ear and bone conduction thresholds. With conductive, there's normal bone conduction but decreased ear conduction. And now with presbycusis, there'll be a loss of the high frequency sounds on the audiogram. Another thing that we can do is a tympanometry. And tympanometry is when you insert a probe in the ear and there's a tone played. There's a microphone there that's going to actually measure how much sound is reflected back from the eardrum as the pressure changes. So what this does is this can detect fluid, perforation, eustachian tube dysfunction, any middle ear pressure issues. Basically, this test is going to assess the health of the middle ear. Another thing that we can do is MRIs and CTs. These will detect any kind of structural abnormalities or an acoustic neuroma. So how do we treat these? Pharmacologically, steroids and antibiotics can be used. Now, non-pharmacologically, there are a few different options. For a mild to moderate sensorineural hearing loss, presbycusis, hearing aids could be useful. If they have a severe bilateral sensorineural hearing loss and the hearing aids are not working, cochlear implants are an option. Now, with conductive hearing loss, a lot of times you get the cerebral removal. If you have to have a tympanostomy or tubes or surgery, that's how we're going to treat. We may have to refer to ENT, speech therapy, or even oral rehabilitation. Why is this important for the elderly? Well, because if hearing loss is not treated, it can actually contribute to lots of health issues. It can cause a cognitive decline. It can cause an increased risk of dementia for patients, cause them to be socially isolated, cause an increased fall risk, and it's going to reduce their quality of life overall. What can we do as providers? Well, we can perform routine screenings and exams. We can advocate for hearing aids, and when necessary, we can refer them to audiology. And these are my references. Thanks.